just today, this is the case who presented to my OPD 4 days back. Okay, this is the treatment he is on. He was 34-year-old male who had history of syncope, and it happened some 4 weeks prior to that, but he landed to my OPD 4 days back for evaluation. Patient was prescribed the following medication. This is what he kept in front of. Some physician prescribed post-COVID when he is complaining of palpitations and some ECG changes. These are the medications he was on. We don't know any other prescription. Amiodarone, escitalopram, clonazepam, here sertraline. And he is on olmesartan with hydrochlorothiazide at that time when he had hypertension. He has all the milieu for whatever he can have. And this is the ECG I saw. And echo was showing only MVP with moderate MR. I could not understand what is happening, why he had syncope. He is not complaining of any palpitation. So I thought we will evaluate you. I just stopped all the medications, sent for electrolytes, hooked a Holter to see something is going wrong, and asked him to come back. Once I go back, I have to see him. That's the thing. Okay, and the another case, this happened when I started my practice 5 years back. This is how she was shifted from another ICU. Multiple cardioversions. When I saw her echo severe LV dysfunction, patient was shifted on this infusion with a potassium as 3.0. I thought by seeing this ECG, it makes sense. Dobutamine, amiodarone not a problem, but why he need to cardiovert that many number of times? That night I got a call. Patient had spontaneous conversion, torsates, cardioverted. This is the ECG. She is having all the milieu for long QT. See, POs are very scant, saying that there is sinus bradycardia. Whether it is amiodarone induced or underlying sinus node dysfunction, you don't know. QT is so prolonged. R-on-T, very clearly early of depolarization leading that R-on-T triggered activity ectopics. So, she is alive. I just put a single chamber AIA pacemaker, corrected, removed all the drugs. She is doing well. Her EF is now better. It is tachycardiomyopathy, which also improved, and she is doing well with 3 medications, that is losartan and pacemaker and beta blocker. That's it. So, just I would like to mention, so we need to be well aware of this thing. So, we will divide today topic into definition, importance of QT interval, pathology of QT prolongation and torsates, drug-induced QT, risk factors and mechanism, and management and prevention. So, we all know it is a potential life-threatening arrhythmia in our ICUs due to prolongation of QT interval, which is a risk factor for torsates, and simultaneously QT interval is a sign of increased risk of torsates. So, in the studies it is well seen that every 10 milliseconds increase in QTC is going to lead more than 5 to 7% increase in risk of torsates, and if QT interval QTC is more than 500, it is 200 to 300% risk of torsates, which was seen in long QT syndrome, but it applies even to our drug-induced long QT also. And it is seen in that study, they found 28% of patients in our cardiac care units will be having more than 470. See, it is our day-to-day practice, and we will be seeing most of the time ischemic QT prolongation, and congestive heart failure, hypokalemia, amiodarone, all sort of things will be leading to this QT prolongation if we give carefully, and 20% will be having more than 500. And many drugs, both cardiac and non-cardiac, will be contributing to prolonged QT and trigger torsates. That you have to keep in mind. So, brief words about measurement of QT. We all know majority of us, we will measure generally in lead 2 and V5, V6. Whichever is longest, take average of 3 to 4 cardiac cycles, and by using slope method. That is by drawing a tangent from the maximum slope to the isoelectric line like this, and measure the QTC. Okay? Manually. If the U wave is small or T wave is notched, if it is less than 1 mm, you can neglect the QT and you can directly draw a slant from the greater slope one. If the U wave is large, then you need to draw your line from the end of U wave. Okay, next. So, next comes to characteristic. We all know that QTC varies with the heart rate, so we need to have a consensus of heart rate. So, various formulas have been proposed for correcting the QT along with heart rate, because from 60 to 100 we all know almost it is equal, but beyond that heart rates are at bradycardia, there is a overestimation, means the QT is not accurate reflection. So Bezet's was invented, but it is also accurate from 60 to 100, but it overestimates and underestimates correspondingly if it is less than more than 100 and less than 60. So what next? Other methods have been proposed, few based on logarithmic equations like Fredericia formula, which is little better, but still it is having also the same false positive and false negatives. Framingham formula and Hodge also, though they are linear equations, they also don't accurately reflect the corrected QTC. And above that, there is significant inter and intra-individual variation will be there. So this is QT nomogram was proposed by Chan et al. In 2007. This finds better, and it is based on QT-RR cloud diagram, which was done in preclinical studies, and it is supposed to have low false positive and low negative rate. So if you have this one, take your patient, diet tangentially, manually put his whatever QT you got from the manual calculation on this line. If it is above this line, it says that it is definitely prolonged. If it is below this line, it is better. So this also mitigates the what is called inter-individual variation for that heart rate. So this is the ideal method to correct QT. Once you are done with next, what is pathophysiology? We all know IKR, IKS channels, which contributes to phase 3 of repolarization. If anything is abnormal, if it is congenital long QT1, this is abnormal. If it congenital long QT2, this is abnormal. So, and calcium channel mutations all can cause ventricular action potential distortion or ventricular repolarization prolongation leading to. And in drug-induced long QT, this is the main channel which is the culprit, IKR channel, which is contributing phase 3 of repolarization, which leads to prolongation of QT and leads to oscillation of membrane potential contributing early after depolarization. You can see QT is prolonged, and the more ventricular repolarization is prolonged, there can be early after depolarization, which if leads to trigger large area of myocardium, it leads to trigger beat. So it leads to short coupled VPCs, R on T VPCs because of that early after depolarization, and which also contributes to torsates because of a single ectopic will be forming a reentrant cycle because of ventricular repolarization dispersion in all three levels of the myocardium. This dispersion leads to reentry. The triggered activity will initiate reentry because of ventricular repolarization dispersion, we all know. So next, though it looks a busy slide, we know various drugs, whether it is antiarrhythmics, antipsychotics, antihistaminics, antiviral drugs, antibiotics, which are daily to day-to-day practice, and common drugs like pulmonary hypertension drugs, and even antiemetics like ondansetron. Almost all drugs are having, but we should know which are high risk, which are some risk, and which are low risk. These are latest thing in proposed. See, high risk is whenever the baseline QT is going to prolong more than 20 milliseconds after initiation of drug, that is going to high risk. Our common drugs, we know they are antiarrhythmics, which are going to prolong in dose-dependent fashion. Antipsychotics also prolong QT interval in dose-dependent fashion. If we have this slide, we can understand which are the high risk, and we should be more careful enough. And we all remember during our COVID days, chloroquine and azithromycin combination was prescribed left, right with our antihistaminics. They were having high risk, so we should be very careful enough for that. So, but all QT prolongation doesn't lead to torsates, because we all know Cardron paradox. Though QT prolongation is much higher in Cardron, the risk of torsates is low because of two things. One is it is homogeneous prolongation across all layers of myocardium. Second thing, it is multi-channel blocker. We all know the first channel to block is in fact alpha blocker. That's why hypotension. And both IKR, IKS is blocked, and even calcium channel blocked, beta blockers all blocked. That leads to minimization of early after depolarization. So that leads to low arrhythmic risk, even though that's compared to arrhythmia. This one, sotalol is having higher at 160 significant torsates. Ubitlide was marketed like hell. We all know it is having highest risk of torsate because of the same phenomena. So we have to be careful enough these things. And next thing important is drug interactions about these drugs. See here, we can see here, this is also important to be known. See, if we prescribe azithromycin with amiodarone, there can be inhibition of substrate leading to long QT, simultaneously other drugs. So genetic predisposition of drug-induced long QT in the form of subtle form of long QT, underlying congenital long QT in them, they will manifest when the drugs are prescribed. That you have to keep in mind. So, and other mechanism is the metabolism slow metabolizers, rapid metabolizers of cytochromes can also lead to change in drug-induced long QT. So there are some risk factors which are modifiable, some are non-modifiable. We have to understand that whenever the drug falls in the high-risk category or medium-risk category, try to correct your modifiable risk factors, whatever being seen, dyserglycemia or renal dysfunction, drug interactions. Try to avoid other drugs which are going to be there and give slowly. Don't give rapidly this one. And non-modifiable risk factors anyway will be there. So these things to be considered. Congenital long QT, female having more QT prolongation, underlying structural heart disease. That's why we all fear to start class 1C drugs if there is underlying structural heart disease. So, and epinephrine surge like FIO, subarachnoid, in that settings also, we might have seen in our ICUs, the QT will be prolonged in subarachnoid hemorrhage and all. So, all these things. Like I mentioned, post-cardioversion, you have seen my second case, post-cardioversion is significant QT prolongation. So, this is the last two sets more important. So, what to be done? There are multiple clinical response systems which were developed in US to support their healthcare system to warn based on electronic medical records what is the QT of that patient. Is it too prolonged? Immediately warn the prescriber to stop certain drugs. Such things were developed. But all those things, once the patient is admitted, QT is prolonged, then it will be monitored very rigorously and informed. Is there any score that will help us for clinicians? This Tisdale score is recent one and it is good. It is verified, validated in 300 in cardiac units where based on clinical scenario itself, you can know by these risk factors what is the chance of patient developing any QT prolongation. Low risk, high, intermediate and high risk were there based on scores, Tisdale score. And they found out that in low risk group, the QT prolongation interval is 15% only, 37 in moderate and high risk group 77%, and predicting the risk of long QT. Then how to manage? This is the flowchart seen in the same this one. If it is low risk and there is no concomitant QT prolonging drugs, no risk factors, no monitoring required. If any other drugs are prescribed along with whatever thing is there, monitor baseline, repeat ECG. But if patient is having already high prolongation, check baseline, monitor once the patient reaches steady state level and try to manage accordingly. So last slide. So avoid high risk drugs in a combination in high risk patient based on that. If it is more than 440 QTC, avoid high risk drugs. If it is more than 460, avoid even medium risk drugs. If it is more than 500, avoid all QT prolonged drugs even if it is low risk. Change from baseline therapy to more than 60 milliseconds also. Stop all tertiary depoint causing drugs. Stop at least 5 half-lives before proceeding to other drug. No special monitoring is required. Anyhow, we all know magnesium is the treatment. Irrespective of the levels, give magnesium because it decreases the calcium influx and prevent early after repolarization this one and leading to decreased risk of torsates. You can repeat the things also. And if it is bradycardia associated, please go for beta isoprene or try to do temporary pacing till the thing fades away. And if the patient bradycardia can't be avoided, please prescribe PPI. If drug can't be removed and bradycardia is also there, go for AICD implantation. This is the treatment. Take home. It is more common than thought. When you are prescribing, take that risk score, Tisdale risk score, and try to assess the risk beforehand itself, and try to modify the remove the modifiable risk factors, and try to prescribe drugs according to the things. Thank you.